the goal of this session is to actually give a quick overview, well, a brief overview, I don't know how quick it'll be, but a brief overview of what is known in ALD and AMN natural history, and just as importantly, if not more importantly, what we need to do to get to the next steps for developing good clinical trials, good outcome measures, and so on. And so Asif is on borrowed time. He was very kind to work around his clinic schedule today. Asif is going to be starting out. Asif Paker is at Bluebird Bio as well, and also sees patients still at Tufts University Medical Center, and has a great deal of experience in the ALD field, and has done written some nice papers on natural history of childhood cerebral ALD. So I'm going to pass this to Asif. We've got a couple speakers following behind him, and then we will have time at the end, hopefully 15-20 minutes for panel discussion. Thanks.
Thank you. I'm Asif Paker. I've been in the ALD field for past 10 years, probably a little longer than that, and now I'm a clinical lead for ALD program at Bluebird Bio. What I'm going to go through is the natural history and how it makes sense for ALD and for this community. Why natural history is important? Because ALD is a rare disease, and regulatory and FDA, authorities at FDA, look for natural history. We know that we cannot do large studies, large randomized studies to look at the efficacy and safety of these drug products, and for that, natural histories are very important, and a well-done natural history is very valuable. And also, with today's topic is that what ALD can do in this field, how can they contribute? And I think before I go into the natural history, there are three things that I will be emphasizing here, and I'll see that other speakers are also talking on similar issues, is to identify the target population, the subpopulation of the ALD group that has uniform and predictable progression. That's what most of the trials would like to see, that which groups to work on and how to identify those groups that fits best for their product. Second, the thought that have gone through, it has discussed here multiple times this morning, is outcome measures. How can which measures can we use which can give us a good efficacy and safety signal in a very reliable manner in the shortest possible time. We know about survival, but survival outcomes take a very long time and may not be the best ones. And the last one that we haven't talked yet is unmet medical need. We know all ALD community patients are unmet medical need, but there may be smaller groups where unmet medical need may be higher, and possibly it could be a good candidate for an intervention. And for time-wise, we are a little bit short on that, and we have a third speaker, so my time is cut down further down. So I'll skip all those slides, which we all know. And go to the phenotypes. We all know that the elevated very long chain fatty acids results in a broad range of phenotypes depending on the age, progression of the disease, etc. And in short, we can say that there could be progressive dying back axonopathy, which can group together adrenomyeloneuropathy and heterozygous women. I will not be talking about these two phenotypes, but I'll be talking about cerebral inflammatory demyelinating phenotypes that can be between, and 60 to 80% of male patients can have these phenotypes. My slide is a little bit off, but childhood cerebral and adolescent cerebral, that's from birth to 18-year of age group, is grouped as childhood cerebral ALD in my presentation, and I'll be labeling that as CCALD. So that will be both childhood and adolescents here. We all know that the clinical symptoms can start anytime after age of 3. They initially could be cognitive symptoms followed by neurological deficits, but MRI abnormalities always precede clinical symptoms. And if you look at this T1 image, This is top part, this is the forehead, this is the backside head, and these black areas are ventricles, and you can see white regions here are myelin. And when it's white, it's very nice myelinated area. And when you look at the parieto-occipital or posterior regions, that white coloration is gone, and this is demyelination. When you look at the FLAIR image, that demyelination appears very nicely in this combination of colors, and white color is demyelinating region. And when you give a gadolinium, it encircles that region and enhances here. I'm talking about, because I'm going to move to the gadolinium, and I want to give you an understanding of what it means. And you see that gadolinium enhancement is seen across the lesion. So to identify the subgroup of patients, first question was that to identify subgroup of patients who have uniform and predictable progression of disease, we found, and it's been reported, that the gadolinium enhancement is a good predictor of rapid progression. If a patient has an enhancing lesion, they progresses very rapidly. In 2000, Melham et al. showed these results. So look at this graph. On the y-axis is less score. Less score ranges from 0 to 34. 0 means no disease. 30, and as disease burden increases on MRI, scores goes up. And this is, this is over time. In this graph, all these patients had GAD-enhancing lesions on MRI, and on their follow-up exams, majority of them have increase in their scores. And when you look at the GAD-negative patients in the same study, you can see on their follow-up exams, their less scores have been stabilized. In this, in my presentation, I'll be also giving examples of natural history study that was done by Bluebird Bio. We call it ALD 101, and I'll show you that data also, because we're using that data for our gene therapy studies. So in literature, we know that the GAD enhancement predicts rapid progression of disease. When we look at our natural history study, this is the data from there, confirming the findings that Elias Melham had showed, that patients who had GAD-enhancing lesion at baseline, mortality during follow-up time was 80% compared to everybody else. So at that, for untreated, GAD was not given to majority of patients also because there was no treatment further, so it was not considered. But we can see that patients who are GAD positive, they have rapid progression of disease. So this can be used as one measure of identifying the patient group. And when you look at the patient who are transplanted, where we do not have much of that data, so that data is missing where ALD Connect can contribute surely. In early patients, 100% of patients showed resolution of contrast. But when you look at the other functional status, we know that positive and negative predictive values fall somewhere above 70% for that. And median time to contrast resolution is around 3 months, 3 to 4 months. So here I want to say that with this data, we can show that how we identified a patient group that had rapid progression, and further research into other parameters that can also help identify other subgroups, or even smaller group that can do better would be very helpful here too. After the MRI symptoms, neurological symptoms start depending on the region of involvement. It could be vision, it could be hearing, it could be swallowing or motor areas. And Suzuki et al. In 2005 looked retrospectively in all of the Japanese patients and see how long it takes to develop these symptoms. And you can see that this is a very rapidly progressive disease. At the end of the 2 year, approximately 3/4 of these patients are not only have gait and bladder problem, but also have swallowing problems. So probably these are bedridden in another 2 years of time. This is a very rapidly progressive disease. When you look at the mortality, this is in 2007, when I looked at these untreated patients, median time is around 8.6 years. So it's a very long time. We saw that in 2 years, 3/4 are already bedridden, and then it's all another 5 or 6 years of poor health. Well, I will also giving some summary. Patrick Oborg in 1990 with Minnesota group transplanted transplanted a successful transplant in a patient with early cerebral disease, and since then transplant has become a treatment for these patients. And in 2000, Charlie showed, he collected data from 43 centers, and he showed that transplant do work. I'll skip these slides. I'm going fast. So this is the data that I worked with him, and we collected that, showing that transplant do work, but it's a small group of patients that do really good with transplant, and other are, where it does not affect the survival. So this is the survival curve of childhood cerebral patients who were transplanted in early stage. Y-axis is survival, and x-axis is time from first abnormal MRI. We do not want to do it from transplant. We did it from first abnormal MRI. And patients with early disease, blue line here, is survival. It was 95% at 5 years compared to 54% in untreated.
So now that we're moving into more of a pre-symptomatic phase as newborn screening is occurring and we're doing regular monitoring, some of these graphs might slightly change. And I'd be curious, since you know this data probably better than anybody else, years from first symptoms, now here years from first abnormal MRI. Clearly these abnormal MRIs were often already at quite an advanced stage. What we're seeing is a slight shift now where the first MRIs show lesions that often don't even have contrast yet and are then developing contrast. Yeah. And so I just wonder what you think about how this our understanding might change.
Yes, so yeah, I completely agree. I think this is a discussion that, this is a thing that I think very often, because we are doing those studies. And that's where the ALD Connect can contribute. That's why where the whole data collection will make sense, because these are older data. Our numbers wouldn't change because for both groups, that was correct. So they were diagnosed slightly later than when the patient were diagnosed today. So if we think that progression is uniform and constant, probably these numbers would not change. These graphs would move more towards the right side, but the analysis would not change. But that being said, every new intervention has to go through that calculation. And when you look at these graphs and these numbers, they have to add that lead time, or they will look at more current data. They have to look for that current data to compare with that. So that is a very important consideration there. But yeah, so in this slide, I'm trying to go fast because of time constraint. In this slide, the message is that early patients who do better, who are those early patients, and they are the one who have less score of 10 or less than 10, sorry, and NFS, this neurological function score, I'm going to explain that very soon, is 0 and 1. So 0 means either they're asymptomatic or they have only one symptom. If they're more than one symptom, they're considered advanced, and we know the survival is not good in that group. All up till here, I'm talking about survival and survival because literature is only about survival. And that's one of the limitations that if we go with present literature, there's no information about function of these boys. And I'm going to show you some data from our natural history study looking at the function of the patients. To look at the functions, one thing that Keith is going to talk about is how important patient portal is in ALD Connect that's going to contribute here. But until we hear back from patients, we use Jerry Raymond's neurological function score to find out what are the functional outcomes could be. So Jerry worked on this neurological function score that have 0 means asymptomatic, and each problem, each disability deficits gets 1 score. We looked at the most severe disabilities like loss of communication in the problem with speech, cortical blindness, tube feeding, wheelchair requirement, no voluntary movements, and total incontinence. And so these are severe disabilities in each functional domain. And so, well, if patients have these, probably they have the major functional problem. They probably are, they should be not functional. And we used that as a MFDs, major functional disabilities, and looked at our natural history data again. And that confirmed that what we knew from survival, that transplant works. So the patients with GAD enhancing lesions did 2 times better than non-treated patients. And when you look at the patients with early disease, they have done even better. So this confirms what we knew from survival data. But now let's look at, survival takes longer. We were using functional status to get this, to learn this earlier on. So I'm going to compare in next 2 slides is how survival and MFDs compare to each other. And this is the survival Kaplan-Meier curve of untreated patients. Black line is overall survival that you have previously seen, and blue line is their functional status. And we can see, first of all, we save this much of time. So 74% of patients here are alive, but only 25% are functional. And we know this at 2-year time point. So there's in shorter time, we know that how their outcome would be. And the other thing is they both follows the same trend. So trend is same. So these are very, they're in line. Now let's look at the patient with advanced diseases. And this is the curve of the same curve showing survival here and the function in advanced patient undergoing bone marrow transplant. And you can see a very stark difference that these patients are alive, but their functions, they're almost function is very low here. And that gives a much better understanding of when we were already saying that transplant should not be recommended for advanced patients. This is very good evidence here. And that's how a new different parameter can really change the recommendation. The other part is, so the third question was if there's unmet medical need, if there's a certain group, a small group that where a new intervention can really be beneficial. To look at that, let's look at the safety and efficacy data of transplant. Wes Miller from Minnesota, look at the largest cohort of transplanted patients from Minnesota. And in patients with early disease, this is the data from early disease, they both have less than 10 scores. There's a group who were transplanted using unrelated donor. Their survival is not as good as patients who received related donor. So transplant physician know, Troy knew this thing from day one, that matching is important, and what graft source have these, knew the outcome of that, but we didn't know. So we know that these unrelated patients who do not have a good donor have poor outcomes.
But Asif.
1 minute. But why this is important? Why is this important? Because all the malignancy data, when you look back, they say approximately 20 to 30%. You didn't do a good job. You gave him a thing. 20 to 30% of the patients have matched sibling donor. Okay, but when you look at the CIBMTRs or the federal data collecting on ALD, it's only 8% of patients have 5 to 8% of patients have matched sibling donor. So it's majority of the patients who do not have a good donors have poor outcomes because of the matching status, because of the source of the donor. Now, when you go ahead, Troy. Now, why don't you ask your question?
It shows that there's no significant difference.
Yes.
The P
yes. So that's correct. There is no difference. It's very small numbers, but so I'm not saying so. Statistics is never fair. There's a biology here. We all know the biology-wise allogenic and a patient from unrelated transplant, you can verify that. The patient from allogenic or unrelated transplant have very different antigens, and the engraftment failure and graft versus host disease is higher in those patients just based on biology of this graft.
I agree with you, but if you're just going by the data, the data says there's no difference.
Yeah, there's no difference.
So,
I agree with that.
But I do agree with you conceptually. Yeah,
Yes.
you're right. But
Yeah, this is survival. This is survival. I'm going to show you the function data also. And so majority of patients do not have the optimal donor available. And with donor, there are two types of main problem. Either host cells reject the donor cells, that's engraftment failure, or the donor cells reject the host, that's the GVHD. And these are not benign concepts. Unrelated donors have 2 times risks of, transplant-related mortality is higher, and they have 3 times risk of engraftment failure compared to related donors. And graft versus host disease risk is also high. And Wes Miller and Charlie Peters show that 1/5 of patients who died of transplant, 1/4 was due to graft failure or GVHD-related complications. So these are not benign complications. Let's look at the MFD. Let's look at the functional data. Does it make sense? So in our study, so this is a complicated table. So this is the whole cohort. If you focus on this one, these columns are match related. So these two are matched, and these two are mismatched groups. This is survival, and this is function. And you can see that patients who have mismatched donors, their function they're poorer than the matched donors. And this just in the end of the 2 year, you can see that difference. In survival, the numbers are very small. If you see 72 to 80% compared to 90%, but on function, you can clearly identify that earlier. And to Troy's attention, P is 0.0. So it's significant. Same trends are also seen in early patients. So point is,
but there are 2 different cohorts.
yeah, so these are all cohort, and this is the patient with early disease. So
What's the whole cohort?
whole cohort is both advanced patient and early patient.
Okay.
It is good to see that because for donor-wise, for transplant-wise, it doesn't make, so graft is not making differences, early disease or late disease. So we see these GVHD and engraftment failure. And when you have larger numbers, you get a better analysis. So, but same trend is here also. Yes, Karen?
What about half-matched donors?
So very good question. There was no haplo donor in this group. This is a new, this is in field, but for ALD it was new, or in our data we did not have any patient who received that haplo donor transplant from their parents. But there will be, they are rare. I'll show you how we are using these outcomes in 1 or 2. But one thing I should say that this natural history study that we did is, in the end of the analysis, in the end of the whole study is done, we'll give this data to ALD Connect. It will be available for you or any other company or institution to look at it, to tease it out, to use it for your trial as you want. It will be available. We're also conducting a similar study for patients who are getting transplanted now. So it's a prospective study, ALD 103. And in the end of that study, that data will be also available to ALD Connect and will be open to all of you for your use. Okay. So I'll go quick, and we see we're using those MFDs as our primary endpoint for gene therapy study. And we are using a lot of other parameters as our secondary endpoint, like changes in less score, NFS. I'll go down here as a proportion of subjects who maintain NFS of less than equal to or less than 4 in 2-year period. So you see how we can use these scores if you're collected in a very systematic way, and same thing for less NFS and less scores. And same is true for graft transplant-related parameters, that if we collect that one in a good systematic way, it could be used for any future trials, and we're using them here. And similarly to other parameters that are not very common, like neuropsych or cognitive ones, or lab measures like ALDP protein or very long-chain fatty acidosis. I will stop here. I just want to say that we also have adult cerebrals, or the patient that should not be forgotten. We have minimal amount of information out in literature. Almost nothing is available. And future trials are going to come very soon. And ALD Connect's contribution to this group is paramount. It's very important. We need all that data that I showed for childhood. We need that for adults also. So this is something that ALD Connect can pick up, and from Bluebird, I'm willing to help by any measure. By any measure for that study, we are here to help you. Okay, thank you.
Hi, everybody. I'm Kathy Zakowski. I'm from Kennedy Krieger and Johns Hopkins. And as I mentioned earlier, I kind of have a different perspective in that I approach this from a rehab point of view. So I'm going to talk to you about outcome measures with kind of understanding that that's my angle. I was given access to natural history data that we have at Kennedy Krieger that was taken from the Lorenzo's oil trial. And so from that, we have 148 patients, up to 6 visits in people, quite a few observations, lots of variables. And so this was sort of the start of the process. And what I decided to do to start with was really to hone this down and look at a clean set of data of patients who are only on the placebo. We don't know, we don't have an idea exactly of how the Lorenzo's oil changed their behavior, but just to be most safe, I went to a group that was just the people who were on the placebo. So it's much smaller, but I've really tried to kind of get to the clean results that we can get. There were 30 men, 44 women, all in around their 40s. The EDSS score is a measure of disability. So 0 is normal, 10 is death. So 4 was about moderate disability. They have a variety of years of symptoms, and their C26 levels were pretty equivalent. Oops. So what we do in the lab is we measure, we have clinical measures. And so I can measure strength, sensation, balance, and different varieties of ways to measure walking. And what I'm going to talk to you today is we use I don't know if I'm going to build oh, there you go. So I use a handheld dynamometer to measure strength. To measure sensation, I use a device called the Vibratron, and I can give you more details, but again, given short time, I'm just going to gloss over the details, and I'll be happy to talk to anyone. The Vibratron allows me to get a measure of vibratory sensation for each person. We have a force plate in the laboratory that allows us to measure sway amplitude, or balance is what I'm calling it for today, just how much we move as we try to stand still with different variations of eyes open and eyes closed. And then we used, I have a timed walking measures for this group as well. So how fast can you walk 25 feet? How far do you go in 2 minutes? Those kinds of standard clinical measures. I'm going to give you the bottom line quickly in that we measured strength in the legs for the hip flexors, hip extensors, hip abductors, and adductors. And what we found is that the hip flexors, which are the muscles that allow you to flex your hip or bring your knee up, for both men and women, we could detect a change within 36 months. And I'm reevaluating the data right now, looking at 24 months as well, but I can't tell you the results of that yet. But that was encouraging. I'm showing this here just a sort of a pictorial way. So for number of months, strength is on the y-axis. Women are in red and men are in blue. So hip flexion is one measure that we think is sensitive enough to detect change over time. We also measured balance. So I looked at how much did the person move with their eyes closed and their feet shoulder width apart, if they close their eyes and put their feet together, if they kept their eyes open and put their feet apart, and if they opened their eyes and kept their feet together. So essentially 4 conditions. What we found again is one condition popped out as the most significant, showing differences from baseline to 3 years. And in this case, also differences between men and women. This is just pictorially showing the same thing over time. The women are in red, men are in blue. So balance seems to be another sensitive indicator over time.
Are you looking at 24 months for that?
I am, right. For all the measures, I'm going to go back through and see if over 24 months, because ideally that would be faster and better, right?
Because it's ground for a week.
It does, yeah, it's not, it's a typo. I noticed that and I was like, that's months. It's definitely not weeks, right? Sorry.
And the dip you saw there?
Yeah, that's what the data shows. So part of the dip is, let me see if I can go back. Part of the dip is that at 36 months, we drop at least in half with our sample size. So people that were, the study ended before it was completed, right? So that's part of it. You see it in strength as well, that there's a change. I'm much more confident in what I would say at 24 months than 36 months, given the sample size. Okay, so part of determining a good outcome is it sensitive enough over time? Part of it is it responsive to an intervention? So a different cohort, this is a much smaller cohort, but I think it's relevant to what we're talking about today. That's why I wanted to show it. We'll look at this responsiveness. So I did a study with heterozygote women looking at whether or not we can make women stronger, and using imaging as well as the clinical measures, can we predict how people will do? So I'm only going to show you now the fact that we tested, ideally it was 15 and 15, but we ended up with 14 AMN women and 12 age and gender matched controls. And the protocol, really briefly, is just they came in for an exam at the beginning. They went to a Curves, which is a gym for women. They're all over the world. And the gyms all have the same equipment. So they were given the exact same exercises to do. They were asked to do them 3 days a week. They kept a diary. We kept in touch with them. We have measures of compliance for people who are interested. And then they came back after 12 weeks. We did a clinical exam again. And then we said, you know, you can keep going to the gym or not, but then come back again after 12 more weeks and we'll reassess you. I'm going to show you just the difference from baseline to post-training for the purposes of showing responsiveness today. So I measured, again, strength and walking velocity. And the way we do walking velocity is, I don't know if I can start this. This is a gait right mat. I wanted to show that it's essentially a censored walkway. So as the person walks on the walkway, we can measure not only their start and stop time, but also spatial temporal parameters of walking, which I think could be really interesting and really valuable to detect subtle differences too, and hasn't been done in AMN before. I can tell you from the exercise study, the women and the controls showed a change in their strength over the 12 weeks. And a change in their walking over the 12 weeks. I also looked at self-reported quality of life and pain measures, since this seems to be an issue that comes up over time and no one had evaluated it very much. And what I'm showing here, this is it's the measure of quality of life on the y-axis. So larger numbers are better. These are the individual AMN patients, with the red bar being the average and the standard deviation. Same thing for controls. And we can see that there's a significant difference. AMN women report worse quality of life given this rating scale that we're using, this survey. So I wanted to relate that to walking, because it's true that it's been shown in lots of other pathologies that walking is a really important goal for many people, and so this affects their quality of life. But we do have to keep in mind that walking is important to people who are at a stage where they're able to walk, right? And so at some stage, the walking measure is not going to be as relevant, because walking won't be what they're able to do, right? So keeping in mind that any outcome measure we pick, any clinical outcome measure, has a floor and a ceiling effect, and we need to realize that and kind of work within the bounds of that. But what I'm showing here is that on the x-axis is how much the women's walking speed changed over the 12 weeks, and each dot is a person. And then the y-axis is how much their quality of life score changed. And then the colors of the dots represent what their baseline quality of life score was. And you can see that, so for example, this person had a very high baseline quality of life score, and their walking velocity didn't change very much, versus the person who had a much bigger change in their quality of life score. They also had a bigger change in their walking velocity. So to sum that up, AMN participants that made the biggest change in their walking velocity also report the biggest improvement in their quality of life. So they are linked, but again, it's not a perfect measure. I wanted to touch on pain because this seems to be really to come up more and more. And so of within this group of 14 women with AMN and I think 12 controls, what I'm showing here are red areas where people specifically pointed or told me that this is where they feel pain. And then there's a number in each circle, and that represents how many people said that particular area. It's a vague way of showing it, but I thought this would give us the idea that in women controls of the same age, there's very little pain relative to what you see that the women are reporting. If we look at a survey that they also filled out, which included that picture that I just showed you, which I'm showing here, this is severity of pain, and higher numbers are worse. And these are the AMN women with the average shown here. And these are organized by severity of pain. So AMN person number 1 had no pain versus AMN 14 had the worst pain in the group, right? But you can see a huge significant difference between the women in the study with AMN versus their control counterparts. So to summarize this part, I wanted to make sure it's clear that we know that strength and walking measures are responsive to an exercise intervention. We know that quality of life, at least by the measures that we have, is worse for the women in our study compared to controls. We know that walking can improve and is linked to what we can quantify as quality of life, and that pain is a bigger problem for individuals with AMN compared to controls. Now, part of what I wanted to get at is a discussion of what are kind of the next steps with this, right? So these are the questions that I came up with, talked to Florian a little bit about, but I'd like to get feedback on this as well. So what's the best way to use these methods in a larger clinical trials across centers? So that's a big thing that we're trying to focus on, right? Since it's such a small population, can people do the same tests across centers? And we think that that's very doable. This is kind of the battery of tests that I think would be really important to capture in this group. So to measure strength in the lower extremities, using a handheld dynamometer, but there are better methods that we could use too, and I have ideas for that. Use measuring balance. Force plates are hard because they're not very mobile, but that walkway that I showed you, and I think I have a, yeah, it's called a gait ride or a xenomat. It's essentially a walkway that you can walk on. These are footsteps. You can also measure center of pressure and center of mass from this. So you could also evaluate balance using the same tool that you used for measuring walking. So that might be a more efficient way to do this. And what I need to do is just make sure that the values I get on our force plates are similar to what we have on the xenomat. But I have a xenomat in the lab as well. Measuring walking, then we'd have to sort of discuss is timed or instrumented measures. Timed measures just being, can I use a stopwatch and see how fast you can do a certain distance, or over a certain time, how far can you go? Or do we need the laboratory measures, which our data is really pointing to being more sensitive to change. We definitely should have some measure of quality of life. I chose a measure that I've used in MS before, but I'm open to other options. And then I think we should also be including pain, since it seemed like such an important variable in our smaller study. So these are, I'm going to skip over, these are, so I have an idea of how we could measure strength across centers really reliably, but this device would have to be tested. Essentially, it's just a dynamometer, a handheld type that is on this rotating rod, which allows the person laying on a bed to be able to do different movements. So for this is hip flexion. This would be hip abduction and hip extension, all via this non-mobile bar, which allows us to give really reliable measures for people who don't need to be trained to do these kinds of tests. And then using a xenomat or some other tool just like this that allows us to look at walking and balance in a much more quantitative way. So trying to take out as much subjectivity as we can and still getting to the phenotype. So I think once we decide on maybe a battery or how we're going to do it, we need to know if this can be done reliably. And part of it will be training at different sites, maybe developing certification ways to certify different sites, and then kind of making sure we think about pitfalls that would occur at different sites. But this seems like the most effective way to get at a larger population, since we do have several large centers across the country. And so my last slide is really just to try to get us thinking about what should we focus on this year. The development of tools that can be used across sites, finding better biomarkers than what we've seen, and how we train at these different sites. So I'm going to stop talking and see if people, these are the 3 questions I wanted us to focus on, and if there are others that people want to focus on, I'd be happy to do that too.
Okay. So my name is Eva Ratai. I'm the MR spectroscopist, MR physicist here at MGH main campus. Can you hear me okay? So I do mainly spectroscopy, actually. So just a little introduction into MR spectroscopy. So basically, MRS offers the unique ability to measure metabolite levels non-invasively. So here's a spectrum of a healthy control at 3 Tesla. So the things that we can see is myoinositol, which is an osmolyte that is primarily concentrated in glial cells. So an increase is typically associated with gliosis and inflammation. Choline is a membrane marker, and an elevation is associated with cellular turnover and also inflammation. Then we can see creatine is a marker of energy metabolism, since phosphocreatine acts as a reservoir for the generation of ATP. We see glutamine and glutamate neurotransmitters. An excess in glutamate could be neurotoxic. A very important marker is N-acetyl aspartate over here. And that's a marker for neural health and viability. It's primarily located in neurons. Then we see lactate. Sometimes it's associated with anaerobic glycolysis, and lipids indicate necrosis. So this is basically the normal spectrum. Several years ago, Florian actually showed that spectroscopy can predict lesion progression in children with ALD. So here's a patient where he placed a voxel adjacent to the enhancing, not really enhancing, it's T1, right? It's like the flare abnormalities. So basically juxtalesional, and in normal appearing white matter. And when choline was elevated, so that was the inflammatory marker, and NAA was decreased, that was typically a sign that this kid would progress. So 3 months later, we have the MRIs again, and you see that this patient actually progressed, while this one didn't, and spectroscopy could basically predict that. Then when Florian came to MGH, so we basically jumped on the 7 Tesla system. At the time, that was brand new. And we were asking, is spectroscopy able to distinguish between phenotypes? So we did a small pilot study with 9 controls, 5 AMN patients, 4 patients with adult cerebral ALD, and 4 heterozygotes. And we see that N-acetyl aspartate, our marker for neuronal health, is decreasing even in AMN patients. In addition, we see that glutamate is also decreased in basically all patient populations. However, the inflammatory markers like myoinositol and choline are not different in AMN or heterozygotes compared to controls just in adult cerebral ALD. So we know that spectroscopy is useful as a biomarker, but there is certainly need for standardization for spectroscopy. So here's these are 3 spectra taken with the same sequence at different hospitals, also different volunteers. And you actually see that if it's done by MR spectroscopists, you know, in a proper setting, they look pretty much the same. You can't actually distinguish between them. The only way you can distinguish between them is, you know, how well did the water suppression work over here. So another thing I want to point out is if it's done properly, also the retest reproducibility is between 4 and 2%, depending on the brain regions we evaluate and depending on which metabolite we're looking at. And that is actually pretty good. So there's certainly need for standardization for spectroscopy. So we were just awarded an R1 that was spearheaded by the University of Minnesota, but the PI was Gulinos. So it's the Partnership for Magnetic Resonance Spectroscopy Biomarker Development. And so it's across 6 sites. And the objective is to establish the feasibility of widespread clinical use of advanced high-field MR spectroscopy technology in a strategic alliance between MR physicists and physician scientists in a multi-center setting. So the first thing is to validate spectroscopy in phantoms and healthy controls. Then we were actually using a rare hereditary disease with definite diagnosis. We used spinocerebral ataxia, and then we want to move to a more common disease like Alzheimer's disease. So here is basically the grant. So in phase 1, it's technology, automation, and refinement. So MR physicists and software engineers need to basically come up with the proper sequences that will allow us to get low coefficients of variance. And so we will test this on phantoms and healthy volunteers. Then we will translate this to 4 different sites and 2 vendors, actually in patients with spinocerebral ataxia. So at this point, we basically have to validate the reproducibility of these sequences. And then at the end, we go to a more generalized approach where we look at Alzheimer's disease. So basically, we're trying to go from a lot of MR expertise to an automation where basically MR technologists can just place voxels and it's going to be validated and very reproducible. So we go from the efficiency, so performance under ideal conditions, so where spectroscopists and physicists are still involved, to a stage where we actually a performance under ordinary conditions, where no physicists are involved, just MR technologists, and it should all be automated. That's the idea. So the phase of automation involves the selection of a volume of interest. So basically atlas-based automatic voxel positioning so that nothing can go wrong in terms of where you place voxels. One thing that spectroscopy is always bad with is zero inhomogeneity. So we want to look at how we decrease the line width, which we would do with automated fast map. And then a decision on what pulse parameters we should use. We decided to go for what is called a semi-laser, which uses adiabatic pulses to avoid any chemical shift artifacts. And then at the end, how do we quantify? So at the time, we decided to go for VESPA, which we can actually integrate in the MR scanner. So then I was thinking, so how could we actually do this in AMN? So how would we start a multi-center trial here? And so far, I've talked to Gulinos at the University of Minnesota and Peter Paker at Johns Hopkins, and Florian, obviously. So we decided the field strength could be 3 Tesla. Vendors, we would be open to everyone. I have more experience with Siemens, but anything. Then probably single voxel spectroscopy because it's just easier. Then the brain regions we can still discuss. We were thinking, parietal white matter, frontal white matter, and probably splenium of the corpus callosum. Voxel selection, hopefully at the time we will have this atlas-based automatic voxel positioning. How do we shim? Probably either fast map or gradient echo shim. So hopefully that may be automated by the time we start this here. Again, a laser, semi-laser sequence, ideally, because to avoid any chemical shift displacement, vapor water suppression. And then right now we could quantify everything in LC model offline, or it's still in the pipeline. We can also try to get VESPA on these scanners and do this automatically directly on the scanner. So this is open for discussion how we want to, and everybody is invited. I want to invite everybody to participate if you want to do like a multi-center spectroscopy trial on AMN. So that's what I have on this one.
Thanks.
Alrighty.
Maybe we'll take 5-10 minutes or so, and we can answer questions. Kathy and Eva, do you guys want to sit up front for just a few minutes? I think what we can do is see if there are any questions from the audience on that were generated by the talks or important points people wanted to make, and we'll start with Amber.
Thank you for these presentations, really nice results. Question, I guess maybe Kathleen, this is for you. So you're capturing a lot of the symptomology in AMN. One of the things I'm hearing, but it could just be anecdotal, is fatigue. And I don't know if that's something that should be captured, because I know there's some validated measures. Do you have thoughts on that? And I want to say Ali mentioned it as well, but I'll let you answer that.
So the problem with fatigue is it's hard to determine the mechanism, right? So central versus peripheral, and to measure it, the only thing that I know that's really been validated, and not in ALD but in other diseases, has been using surveys, right? So there's fatigue scales. So I mean, it wouldn't be very hard. It could even be put onto this the Neurobank. You know, I don't know if it's on there actually yet. We talked about it, but I don't remember. Is there a fatigue scale survey on Neurobank?
I don't.
Okay. Because that definitely would be very easy to do and not a problem. It would provide some information. We really do need better measures. I am working on a study right now looking at using, trying to quantify fatigue in a better way that would relate to at least central fatigue, which was what you would probably figure it would be related to ALD too. So I think there are things coming down the pike, I guess, that might be more quantitative.
I guess there's some easy ones. My thought is, I mean, I would love for you as an expert doing it, but some of these, I think they're like, 8 to 10 questions that anybody could answer, and let's maybe start collecting. Because again, the way you were surprised about some of the pain, or maybe you weren't surprised, I was a little bit surprised. And the reason fatigue's coming to mind is there's some treatments out there now in other disease areas where it seems to be giving patients some symptomatic relief in the fatigue space, and somebody said, well, is that an issue for AMN? And I don't know.
Yeah, so I don't know either. Yeah.
I mean, maybe this is where we can take advantage of the patient portal or Neurobank, where people can start answering 10 questions once every 6 to 12 months. And if there's no signal, let's not get excited about it. If we see a little bit of a signal, then somebody like you can really make something out of it.
Right, that's exactly. And I think we should also not try to reinvent the wheel, but use something that's been standardized and validated in another population that might have similarities to AMN or ALD. But I agree.
That was great, Kathy. So I had a question about your exercise regimen. So you did this in women,
right?
But presumably that would also translate to men.
Mm-hmm.
And maybe a question for some of the industry folks, how would FDA view an intervention in the setting of an exercise regimen? So I know this is sort of happening now in the field of Fragile X and other disorders where there's a lot of heterogeneity. And the thinking, I believe, is that being on a common exercise regimen helps create, reduce some of the heterogeneity over time. And is that even a viable approach, given how much we're struggling with nobody wants to embark on a 3-year trial of AMN, right?
So I would love to hear people from industry, their point of view, but I'll say that when we designed the Lorenzo's oil trial, we did exactly that. We gave everyone an exercise program, and the problem we had is we didn't monitor compliance well. Right, so it's very hard. The reason, the beauty of the curves idea is that it's a established gym. You have a card, you walk in the gym, you put your card in, it's red, so I know you've arrived, and I know what you're doing when you're there. if we do an exercise program, we need to think very carefully about how to standardize it. I think it's a really important idea too, because we can make it fairly standard. I just think we have to think more carefully about the design, because we tried to do that in Lorenzo's oil in a very subtle way, and we just didn't monitor carefully enough. Yeah.
This is a question
okay.
for you. I'd just like to hear some of your maybe some of your thoughts about implementing mobile apps to accomplish some of these things. Now, obviously, strength is probably not going to be accomplished there, but the balance, walking, quality of life, pain, all pretty much self-reported type of metrics. Right. And I wanted to know your thoughts about incorporating something like that. What are the limitations and strengths?
Right. I think it's a really important, I'm glad you brought it up, because I wanted to talk about sort of low tech versus high tech. And I think the technology using accelerometers is really, really skyrocketing. And it's what I've found. I just wrote a grant trying to implement this. What people are doing is very simplistic. We have much greater capability to get at the raw data that the accelerometer outputs and use more sophisticated analysis to get at things like intensity of activity, activity in the night versus in the day, and how does that affect, so how does your activity at night even affect what's happening during the day? I think it could speak to issues like fatigue. I think there's a lot of capability, but it is not being done right now. So I've been working with a statistician at the School of Public Health to try to look at these variables, and what's been done in the field of aging they have kind of led the way. So they have been able to determine differences in 5 and 10 years of difference of adults, even just looking at activity patterns. So I think that would be one way to do it. I think you're also asking if we can standardize tests that can be done more commonly. I think that's definitely very doable from a person's home, because you can just upload the data. It's going to be a matter of assuming that people are doing them all the same way and training people. There's also new technology coming out of Oregon Health Sciences, where an engineer is devising these sensors that get plugged in your home, and essentially it triangulates where the person is and where these sensors are, so that we will know from our lab in Baltimore exactly where the person is in their home and what they're doing without video or anything. It's just looking at the signal from these 3 sensors. And so that is also I think offers a lot of potential for doing something within the context of what's important to people, which is how do you move when you're doing what you want to be doing, versus in my lab where it's tile and it's well lit and you're trying as hard as you can. That isn't realistic, really. So I think is that sort of what you're getting at?
Yeah, it is actually. Now, obviously, some of the tools that you're using in your lab are obviously going to be a lot more sophisticated than something that I carry around in my pocket.
Right.
But is there a benefit to having more people participate? While you don't get the same kind of quality of data, you have more of it?
Yeah, I think that's a start completely. If we could devise a way through Neurobank even that we could upload data, I think that would be great. So the issue with the phone is that as a woman, I don't carry it in my pocket. So then I don't get the same type of activity as you might when you carry it in your pocket, right? So, but you're right. Maybe this would just be an easy way to start gathering objective information. As long as, I think the caveat we should be really careful about is whoever's looking at the data from Neurobank, it has to be done really carefully and thoughtfully, because you can misinterpret this very easily when you don't get the context around the numbers. You're just getting numbers, right? Yeah.
Let me suggest that if you had an iWatch like an Apple Watch to offer for entry into a study, it would really help the enrollment, you know?
Well, kind of following up on that,
yep.
I wonder if there's any way we could get whoever makes Fitbit to make an enhanced Fitbit for the benefit of AMN studies and presumably other MS and so on. But that would give you more of the kind of data you might want. And 2 other very quick things. I was in your curve study, as you know, and I had a problem, as many did, because curves seems to be closing around the country. It is a thing of the past decades. So that it was a marvelous, uniform, around the country thing, but I don't know that it's going to be around for much longer. So we need to look elsewhere. And finally, on additional measures for movement, would you might consider putting in self-reporting of trips and falls?
Yeah, very good multiple points. So if I miss them, so the idea of using the Fitbit, I don't even know that we need to enhance what they give you. What I use is slightly different. It's called an actigraph. It's commercially available. It's FDA approved for research, which is really critical for establishing reliable data. But they're like $250 each. So that's, when you consider that one MRI is $650, and that's just one MRI, not multiple time points, it's fairly cheap. So I think using what's available is totally reasonable. I don't know that we need to reinvent an accelerometer. What we need to be sure we get is just the raw data, not just what you see on your Fitbit, which is sort of steps that you take, because the steps are kind of approximated steps, and I would want really the raw data of per minute, what kind of activity, how much is that accelerometer moving, not just modeled step count kind of thing, which is, I think, very useful for day-to-day, but not very useful for research. For the falls, I think that's a really important idea. What I have my patients who wear these accelerometers now do is keep a really basic diary where they report when they went to bed, when they woke up, any falls, and anything else they want to tell me about their day. And the idea is I shouldn't need much more information, but we really can't determine when a fall occurs with the accelerometers yet, because we can't determine if you've fallen or if you've reached down really quickly to pick up something. So it can look very similar in an activity pattern way. Does that answer your? So thank you. Good questions.
Quick question for Eva. Has anybody looked at impact of exercise upon N-acetyl aspartate and spectroscopy, or is there?
Oh, that is I think people not too much that I know of, but that would be great to include actually another biomarker in so combine that.
Yeah, agreed.
And we have the imaging already in common.
We could do that.
Yeah.
Right.
And you have Johns Hopkins. You're right, exactly.
Put it into
Yes, perfect. Yeah.
Thank you.
Right.
I also have a question for Eva. The collection of biomarkers that you are looking at, how specific they are for ALD? Did you see similar changes with different neurological disorders? And if you have, are you going to include this as a control group in your study?
That's a good point. So they're not very specific. So N-acetyl aspartate is a marker for neural health and basically is decreased in all neurodegenerative diseases. So that is actually a good point that we could raise. We could have another control group, not just controls, but maybe also MS or, I don't know. What do you think, Florian? I mean, should we include another?
We have it, actually, in Minnesota. In Friedreich's ataxia, we've been doing MRS at University of Minnesota, and NA levels are decreased, and we have now 2-year longitudinal data on about a dozen patients that show that the levels are decreasing over time, and that correlates with neurologic outcome measures as well. So would love to collaborate. And just thinking, there are a lot of measures that you talked about that are measures that we use as well, like the gait right mat. You know, one area where I think we should start thinking about how we collaborate is validation of these, qualification of these biomarkers and endpoints with FDA. I think if we can go in with multiple diseases and say that these measures are good biomarkers and correlate to clinical endpoints that are meaningful for patients, that's a much stronger position from a regulatory perspective, and I think there's a lot of work we can do there.
How can we make all this information available to a larger group of the people?
Jen is now part of us.
a lot of this is published already in terms of spectroscopy. So, for instance, the EDSS correlation between NAA and EDSS, that's already published. Yeah, no, we publish it.
So which part?
No, but we published in 2005 a paper with Prachi that we showed the indirect association between EDSS and NAA. Yeah,
that's on it. So there's a paper that we're working on right now with the exercise data, and the longitudinal data are all in process. So we should have them submitted by the end of the year, but it's not out, so it's not available yet. And I don't want to share the data until it's been at least peer reviewed. Oh yeah, go ahead. You can, and then I'll bring that up. Sorry.
Oh, okay. Are there any findings of pain in men, perhaps earlier in the disease, because older women have a more modest progression?
I don't know that it has been documented. I would tell you from my experience that it's more in women than in men, although I can say that perhaps that's because the sensory loss that we can quantify in the men is far more profound earlier. So perhaps they had pain and now they don't feel the pain. That's my guess.
We should probably spare some time for the next couple of talks, but this is one of the most important aspects of what ALD Connect is trying to do, which is understand, in a nutshell, what matters to patients and what sort of things we should target in a clinical trial to understand whether an intervention of any kind is going to make lives better for people affected by the disease. So plenty of time to come back to this, to talk to Kathy or Eva after the sessions, but we'll... Sure, one sec.
Sorry, I promised a couple patients I would mention this, so I want to be sure I bring it up. Several people have emailed me about exercise, what exercises do I recommend and how do you do them, and if you're at different disability levels, how do I adapt them? And it's been really hard because, as physicians will know too, I have a license, and so I can't really treat over the phone or just give feedback that quickly. So what I did is I just did a video journal that is peer reviewed, but has video team came into the lab and videotaped how to do exercises at different levels, and so that will be published online, and then I'll put it on my website, on the ALD Connect website, so that people would have access to that, and so that might answer some of these questions and at least give people a place to start. The video is designed for anyone to view, from a person with the condition or a therapist. So I'll make that available, but I just wanted to make sure people knew about it.